Great to hear the buzz in the room, the buzz in the hall. It was quite a long queue for lunch, so I hope you've all managed to get some food before joining us. There might be a few people still trickling in. I know that some of you will have been here since the morning session, others might just have joined. So it's really fantastic to hear so many great speakers this morning talking about innovation and looking back over the history of the Chief Scientist Office. In this session, we're going to look forward to the next 50 years, which is fantastic to be able to do. So I welcome to this session. I am Christine McLaughlin, Director of Population Health within Scottish Government, and I also have a responsibility for overseeing our innovation work alongside Anna and Tom, who you'll hear from later on. But also have a really strong interest in what we were talking about earlier in looking at how we can use innovation to support the healthy life expectancy of our population. Something that we heard earlier is real strains on the system, and we're seeing declines in areas where we'd made gains before in life expectancy. So it's really important sessions and to allow us to look forward at how science and technology can really support us in doing that. So alongside me to chair this session is Denise Brown, who's Director of Digital Services within NHS Greater Glasgow and Clyde, and we're going to facilitate this session and do our best to finish by around 4 o'clock to make up some time, because I know you've got some really good speakers after this, and I think some prizes still to come, so I know you want to stay with us through that session. So first of all, we're going to start off with a discussion on changing the paradigm of healthcare systems. I'm really pleased to welcome Professor John Bell, who is Regius Professor of Medicine at the University of Oxford, to take us through that. Thank you, John.
Thanks so much, and it's a real pleasure to come here to be able to talk to you. It looks like it's been a great session, and I hope I'll be able to contribute a bit to some of the already active discussion. First of all, the comments I'm going to make don't relate to the Scottish health system, which is obviously perfect. They relate to the English healthcare system. So don't take any of this as criticism of your system. It's a criticism of the guys south of the border. And there is, I think, an interesting story that underpins the fact that in reality, most healthcare systems are under a huge amount of stress at the moment. And there's an interesting argument about whether any of them are really sustainable in their current form. And I think there are answers to those questions and solutions to those questions that hopefully I will get to as I go through my talk. So the first thing I'd like to comment on is that we should actually be pretty positive about the achievements of medicine over the past 30 or 40 years. So my sort of timeline is, roughly 30 or 40 years. It's the time I took to train in medicine, and up to now, there's been massive changes in our contributions to people's health. As you all know, cardiovascular mortality has been reduced and morbidity has been reduced by 70%. We now can cure and contain many of the chronic viral infections. We've got vaccines for all kinds of things. Immune therapies are really starting to show that they can cure a small percent, but a significant percentage of people with cancers. We've got lots of drugs for inflammatory diseases, all of which used to be untreatable when I was a medical student. We've got the first new drugs for dementia and obesity. That's right off the hot off the press. We've got massive improvements in imaging and non-invasive interventions. We've sequenced the genome now many millions of times, and we've extended life expectancy. We've extended life expectancy about 3 years for every decade. And people say, oh, what's that all about? Well, what it means is that when you get to be grandparents, you're all going to have 15 more years with your grandchildren than you would have had otherwise. Now, that may be good or bad, but on the whole, I think it's probably pretty good. And in fact, I would argue that it's probably one of the great achievements of modern science. And I don't think we as a medical profession talk very loudly about this, but the truth is I think it's a massive achievement when you look at it all summed up together. And over time, this, of course, has had a massive impact on demography. And this slide shows you massive shifts in demographic. You don't have to look at the colors down below. You can pretty much guess what they are. But you can see the massive shifts globally on demographic change over this period. And that's really what adds up to the 19 years of improved life expectancy globally over the past 30 years. It's a huge number, really very, very successful. A lot of the biggest gains coming from middle-income countries, but developed economies have done really well as well. So, but that's, of course, a great success, but it's also created the problem. And that is we've got a lot of people living older and not necessarily living well into their older life. And one of the reasons, or probably the single biggest reason for this, is that as people get older, they are exposed to a wide range of chronic diseases. And these are the big population health diseases that actually carry by far the biggest burden in all healthcare systems. And this is fed into a discussion we've had in Whitehall about how do we create a strategy that is a strategy for developing new interventions in the diseases that really matter to healthcare systems, and do it with industry to see whether we can make any progress in that space. And that was a paper that John Simons and I wrote together in 2021. And we created a set of health missions which were to focus on particular areas that were having a big impact on healthcare. And that's a list. It's not a complete list, but it's a pretty good list. Obesity, cardiovascular prevention, not cardiovascular end-stage disease, cancer, particularly early diagnosis of cancer, dementia, respiratory disease, mental health, aging, and prevention. And we chose these diseases because that's where the big impacts on healthcare systems are coming. That's where the big effect of demography is having its biggest effect. But it's also the areas where the health service doesn't, on the whole, they're not interested. And so if you look, I mean, for example, obesity is quite a good example. The healthcare system is not really interested in obesity. They don't view it to be a disease. They view it to be a social phenomenon. And yet it's, as I'll show in a few slides, it's a big issue. And same thing applies to dementia, where health systems don't really, because they can't think of what to do, they don't really manage dementia particularly well. Respiratory disease is left to sit in the community with people not very well managed. Mental health systems do nothing, as far as I can make out. Aging, they do nothing. And prevention, they do nothing. Well, less than 1%. So you can see we've got the big causes of morbidity and challenge to healthcare system, and yet the healthcare systems don't do much in any of those domains. And I think, that's really the starting point of what I'd like to talk about now. Now, the impact of this is obviously a significant impact on the cost of running a healthcare system, but it's also got a massive impact on the economic vibrancy and capacity of any economy. And there was a nice series of papers in the Financial Times that showed this, and that is, post-COVID, it became quite striking that about 20% of the people unemployed in the UK are unemployed because they have a chronic illness. And that creates a bit of a challenge, because the way we've always thought about healthcare is we think about health economics. What's the impact of this disease on the cost of providing healthcare within a healthcare system? When in fact, there's a whole nother domain to this, and that is, what is the cost of an illness, a chronic illness, when it takes people out of the workforce? It causes a drag on the work, on productivity and economic growth, because you've got so many people who are in trouble. And this is an interesting table from that. And you really just have to look and see what's happened since 2020. There's a massive scale, and these are a whole set of chronic diseases: mental health, chronic pain, diabetes, and then a little bit at the top, a few students who aren't doing anything, but that's normal, and the odd retired folks. So, but you can see this is a really serious drag, economically speaking. And I think if you don't get to that, you don't fix this in terms of how you can make a healthcare system really viable. And there are a number of good examples on that list of chronic diseases, but in many ways, obesity is probably the best single example. And, obesity is described as a truncal disease. And some of your Scottish scientists have done terrific work in this space, so a lot of this data comes from them. But if you look at what you end up with, if you've got obesity as the underpinning part, and the UK is the fattest country in Europe. We haven't quite caught up to the US, but we're getting there. And you look at many of the common cancers, the biggest risk factor is now obesity. It's a massive contributor to mental health problems. Much of the joint disease, as Ian McInnes has shown, is due to obesity, chronic renal failure, diabetes, cardiovascular disease, heart failure, the lot. So this is a real problem. And when you look at the impact of that on GDP, there's a lot of flaky data out there, because I've just looked at it. And it looks like at the minimum it's 3%, but it's probably closer to 10%. And the American number is 7%. So, I mean, if you say, well, why don't we take 10% off GDP? You know, that's quite a serious issue. So this is actually more than just a problem. It's a very, very big problem. And as I said before, largely unaddressed by the healthcare system. If you go to see your GP, certainly in England, and you're a bit on the large size, chances are he isn't going to do anything. And in fact, he probably won't even raise it with you. So he's not really interested in obesity. He thinks obesity is a social problem, and it's not got nothing to do with it. So there are some serious problems. And this is a nice slide that shows these are all, you know, huge numbers of diagnostic categories. And the colors here, as they get darker, show the contribution of obesity to increasing the risk of all these diseases. And you can see lots of them are shaded, so almost all these diseases go up in frequency, and some of them go up a heck of a lot. So you can see that there's a massive impact across almost all diseases from obesity, and yet we don't treat obesity. So you can see that there is some fundamental problems in the system. And then if you look at the role of multimorbidity, which of course is the other thing that occurs in elderly people, and you look at the impact of obesity on the risk of a second disease and a third disease and a fourth disease, you can see how the curves really change. So the major driver of comorbidity in populations, particularly elderly populations, is obesity and BMI. And that was during the biobank cohort and in the big Finnish cohort. So, you know, there seems to be no controversy here. This is a major single issue that if you don't tackle it, the problems of healthcare systems are only simply going to get worse. So when you then think about the constraints on the current healthcare system, in the context of that example, and there are other examples of chronic diseases, well, shifting demography I've spoken about, population health burden from those big diseases, the chronic diseases I talked about, but also the fact that our healthcare system, which was designed in the 1950s and has done a terrific job, my first slide shows you all the great things that have come out of healthcare. The problem is that it was really designed to pick people up when they were symptomatic at the end stage of their diseases. And they weren't really interested in people who were starting on a disease course that might have started 20 or 30 or even 40 years before they rocked up in the hospital. And so that is a really big issue, because unless you can address that, you're going to be in trouble. So it's a 1950s model of healthcare, which worked really well. I don't want to criticize it, because in the 1950s, it had a big impact. But the reality is it's probably got to change. The absence of really effective digital infrastructure is still an impediment. It's getting better slowly, but most other industries have moved much faster to get digital infrastructure in place. There's been a failure to adopt technology, which increases productivity in the healthcare system. There's a massive gap in capital funding. But there's also, in many healthcare systems, it's a challenging, and in fact, you could argue a very poor work environment for healthcare workers. And that is a really crucial factor in reducing productivity. There's been a focus on health economics rather than real economics, which I think is a real problem, because you need to think, I think, in different terms than the health economists do. I'm sorry about that. There'll be some health economists out there that'll be very offended by that, but it's just worth a thought. And the workforce model is fundamentally flawed. Lots of doctors, when you've got trouble, train some more doctors. And I'll show you in a minute, the last time we did that, productivity went down, it didn't go up. So I argue it's a bit like fighting the Battle of the Somme. When you're losing the Battle of the Somme, what you don't do is send more guys into the Somme, which is what we're decided to do with our workforce plan. So you got to fix the Somme first, and then it starts to look a bit better. So those are the constraints, but this is what we've got. And there's a lot of nonsense talked about our healthcare system, because when I was a medical student, this many years ago, you know, we always used to say NHS is fantastic, single payer system, it's great, but let's be clear, it's cheap and cheerful. It's taxpayer funded, not much money, we do our best, outcomes look pretty good, but it's cheap and cheerful. Anyway, the reality is it's not cheap and cheerful, it's bloody expensive. We're right up in the top end here, here's the United Kingdom right here, and we're right up at the top, and last year, we were the second, only to America, in terms of the amount of money that got spent in the healthcare system. So when people say, oh my God, let's spend more money on the healthcare system, just stop for a minute and think, that's a bit strange, because Bell showed us a slide that suggested that there is lots of money being spent in the healthcare system, and it's not taking us very far. So that, I think, is a big problem. And not only that, but the numbers have been going up dramatically. So you can see how the amount of money has just gone zip, zip, zip. So this is why, if you look at this chart, so when I was a medical student, which is down here, it is true, we didn't spend much money on the healthcare system. But that's not true anymore. We spend a ton of money on the healthcare system. And that, I think, should give us all cause to contemplate what the problem is. So, in addition to be really expensive, we've also got the worst outcomes. Not the worst. I always say, Victor, this is for you. The great thing about America is they'll always have the worst outcomes. So we know, no matter what the chart is, we'll never be last. But we're second last. So we shouldn't be too proud of that, actually, to be crystal clear. So we spend a ton of money, outcomes are all terrible. So this is all King's Fund data. You can look it up in their report. I'm not making this up. It's all true. So, and of course, there are multiple reasons for that. But I think there are a number of things that fall out when you start looking at the data. And one is that the NHS in England, and may not be true here, but it's certainly true in England, is really a technology-averse healthcare system. It's very old school. It's really, as I said before, a 1950s style healthcare system. And you can see here, for example, the amount of money spent on drugs, and we're right down here, way at the bottom of a lot of comparable countries that spend an awful lot more on drugs, and yet, on the whole, don't spend any more on the whole healthcare system. And similarly, if you look at other forms of technology, scanners, MRI scanners and CT scanners, it's the best example. So you look at all these countries, here's Japan way up here, that's probably a bit over the top, to be honest. But, you know, here we are, this is everybody else, these are all our peers, and here we are, we're sort of about not quite half what the second worst in the OECD is. So, I mean, I don't think there's any doubt the data shows we don't adopt technology, we don't use innovation, we spend too much money, and we get terrible outcomes. It's true in the digital space as well, and that is that whenever NHS England needs money, they always steal it from the digital guys. Andrew will be familiar with this phenomenon. It always goes sideways from the digital pot. And the NHS Tech Fund, this is just a report a year ago that showed that they had skimmed enough off that it was down to less than $1 billion, which isn't the right number for a complex, digitally enabled system. And there are many examples of the failure to invest capital, and some of this you've seen before. So some of this is CT scanners, MRI scanners, but also hospital beds, bed per capita. So there is a real lack of capital expenditure to make the system work properly. Now, there's good data about NHS staff. I've showed you some of this before, but you can see what's happened is that there's been this dramatic increase in people waiting for treatment. But it's not because we've got a lack of staff, because the staff has gone up almost proportionately. But the patients waiting per NHS worker has really jumped, and that's a reflection of the productivity of the system. So this was to the point I made before. You train a lot of doctors, and productivity goes down. It doesn't go up. And this is similar data that shows that the change in the head count, which is really quite dramatic since 2009. It's quite striking even in the most recent years. So there has been quite a dramatic increase in the workforce. Now that workforce is spread out in a variety of different places, but where there's been the biggest increase in workforce has been in hospitals. While in primary care, the workforce has got smaller. And so there's a message there I'm going to come back to, and that is community-based health systems are actually underpowered in terms of the workforce that is available to them, where hospital-based workforces are probably over-endowed with physicians and people working in them. And this is a kind of summary slide of healthcare productivity. You can see how it's slumped, particularly in the last 4 or 5 years. Okay, so that's the sort of depressing bit of this talk. I'm now going to get cheerier, so everybody can. So we don't have to look back very far to be really proud of our healthcare systems, and that was in COVID. And, you know, the reality is that during COVID, both in Scotland and in England, and you know, the famous inquiry may come up with a different result, but my impression was we did pretty well, actually. And we did pretty well because we based it on a whole set of innovations that we introduced with speed and alacrity to get people exposed and making things available to populations at scale. And this is just a few examples. You know, the recovery trial was undoubtedly the best set of clinical trials done during the pandemic. That was all really based on the success of being able to use the health service to recruit into these big studies, and there was a whole set of really important outcomes. The vaccines were terrific. Some of them developed entirely in the UK. We did a great job on testing. Anna was very involved in that, but of course there were many others involved, and this is the lateral flow testing, which of course became very much part of everybody's life. We've got probably the most experienced and expert population at sticking swabs up their nose than any other country on the planet. And you've all done it a dozen or more times. And, you know, that, I remember when we started, everybody said, oh, they won't be able to stick a swab up their nose. Really? Not that hard. Anyway, and you know, these things really made a difference, and and it really did get us to a very different place. And of course, the big population epidemiology studies, and again, Scotland was right at the forefront of this. We had the ONS study as well, and it gave us the data to understand what we were doing and how we were doing it. So when it worked well, we used innovation and technology here, 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 here to get a really terrific result. So it's not as if it's broken forever. We know that we can do it. It's just at the moment on the day-to-day, we don't seem to be applying the lessons that we learned over that time frame of COVID. So one of the other things which is really striking about this, which when you sit back and reflect as to the fundamental problem, we do treat disease very late. You know, we wait till people rock up in the emergency room, hence the emergency rooms are full. You've got people at the end stage of their diseases. About 50% of cancer diagnoses are made in ANIA's departments in England, at least, and which basically means people are showing up with a big lump in their abdomen or some ghastly end-stage disease. And you've got acute cardiovascular events, which we've got very good at, you know, sticking cannulas everywhere. But these are people at the end stage of a long-standing disorder that starts very much earlier. So these diseases all start way back here. We wait till the very end, they pop up, and then we do what we can to prop people up for the last 5 years of their lives. And that's why so much healthcare expenditure is spent in the last year of life, is because you've got people right at tipping off the edge. And that's that's a really serious fundamental problem. And this isn't anybody's fault. We learned how to do it here. That's what we did in the 50s, 60s, and 70s. But we haven't really been very good at getting up here, which is where you have to get to if you're going to stop the development of these diseases. So, you know, some of the solutions to our current problem is to shift this paradigm very much to the left, looking increasingly at prevention and early diagnosis and early therapies, because that, in the end, is going to be the right way to stop and flatten the morbidity curve that you see with almost all the chronic diseases. So there are no chronic diseases that if you treat them earlier, you don't do better in terms of overall morbidity and mortality. You flatten the curve, you get people with much longer and better life expectancies with many fewer complications. So if we can shift to the left, we could make a really big effort. And that's just proved to be really hard, and I'll get into some of the reasons why it's hard, but it does need to be done. We also have to focus on multimorbidity and the big chronic diseases. I've already made that case, and I think there's no question. If you don't deal with obesity, don't expect your healthcare system to be sustainable over the long term. And the same applies to the other big diseases. Innovation is crucial. We've already talked about that, but we've got to do it faster and more effectively. We've got to get digitization and data driven into the healthcare system much more effectively. And we have to do a lot of this in the community, because a lot of this can't actually, if you're going to start way over here, way over to the left on the previous slide, you can't really do that in hospitals. It's got to be community-based. And yet there's this paradox that primary care has fallen over. And as a result, there really is no community-based function. And we have to obviously review the workforce plans. So there is a new model of care, which is what I call precision public health, which is to target people based on their risk of the big chronic diseases and target them very early, right on the left-hand side. Because there are many people in their 20s and early 30s where the beginnings of trouble is starting to be in evidence. Cardiovascular disease, obviously obesity and its consequences are very common in teenagers, early adults. We've got all the issues of a long gestation period for many of the solid tumors. They can be up to 15 years of grumbling away before you get to a diagnosis. So there are lots of examples of things where if you understood who was at risk, you could introduce efforts to prevent those diseases. But you could also introduce efforts to diagnose them earlier. And if you diagnose them earlier, your benefits will be very material. So that, I think, probably lies at the heart of where we need to go if we're going to improve our current healthcare system. Now, there's a great quote here, which is W.H. Auden quote, and I've sort of say I've stole this from Andrew Scott. He knows I stole it from him, but he's written a new book, which I would recommend you get when it comes out in the spring. He's the guy who wrote The 100-Year Life, and he's an economist, macroeconomist, done some beautiful work in this area. But this quote from W.H. Auden, I think, is terrific, and that is, health is a natural state to which medicine contributes nothing. And I'm sort of saying that's sort of true, and that's to my point. In my earlier slides, most of the things that will keep you healthy are not things that medicine is going to do for you. So we do need to pay attention to that. And that I think raises the question about whether expansion of physician numbers dramatically is ever going to improve productivity. It hasn't in the past. And also the fact that medical doctors are actually largely focused on late-stage symptoms. They've been trained in the 1950s model. So I think we just need to get used to that. That's what they know. That's what they love. And changing healthcare systems turns out then to be really, really difficult, because if the profession that runs it don't want to change, don't expect it to change very quickly. And I think there's an issue about medical education here, but I'm not sure we can wait for another generation of doctors to be trained before we get on top of it. So if you're talking about precision public health, this is a system that's based on prediction of disease and prevention, early diagnosis and early intervention. And there's a lot of new tools, of course, that can help you get there. Obviously, polygenic risk scores, interesting new protein biomarkers, digital records, and AI, causal inference, which allows you to predict risk with increasing precision. It's not perfect yet, but it's pretty good. And then, of course, a whole set of tools that allow you to diagnose early. So new tools for cancer diagnosis, new tools for Alzheimer's diagnosis at a very early stage, screening of high-risk populations, tracking of pre-cancer populations. This is a very exciting area of development. And then finally, we mustn't forget that even if you've got a disease, early therapy will be really probably much better than it will if you wait. And so we shouldn't be anxious about treating people early if they've got risk factors that we know are going to cause trouble. And of course, obesity is one of the classic examples of this. Treating people who are obese before they get really obese is almost certainly going to be a powerful new tool. The long-acting injectables, things like inclisiran, the PCSK9, siRNA, the new angiotensinogen siRNAs, these last a year. You get a shot. It's a vaccine for the prevention of cardiovascular disease. Cancer you can treat with immunotherapies, and they almost invariably get better, much better, if you treat early than if you treat late. And the same applies to the early treatment of inflammatory disease, mental health. So what's good about this is we're kind of now starting to explore this as a possibility. And one of the projects which I'm involved in is this one, which is called Our Future Health. And you'll all be glad to hear Our Future Health is coming to you very soon. We're going to get across the border. It's going to be very exciting. And it's been an incredible ride because we set this up, well, we set it up before COVID, but we didn't really start to recruit till after COVID. And in fact, we've really only been recruiting for the last year. And the idea is to bring in a group of consented people. 5 million people is what we're shooting for, so we need all of you to sign up. And the idea is to try and predict who's going to get which diseases, but also screen early to identify who can benefit, and to actually also intervene earlier if that's possible. And also to use a set of prevention techniques for people who are at particular risk of particular diseases. So this is the shift to the left I talked about in a previous slide. And this is an experiment which is ongoing. It involves very little, simply a blood sample and a questionnaire that you do. You can consent online, you can do the questionnaire online, pop into Boots, the pharmacy, or a little van in the Waitrose car park. And it involves all kinds of different partners, both all the major charities, as well as a lot of the major life sciences companies. It's a massive collaboration across the system. And the good news is, if I'd given this talk a year ago, you would have said, oh yeah, that's never going to happen. It turns out that it is happening, and it's happening at scale. Each one of these little dots is somebody who's signed up, and you can see how we're getting on here. I'm sorry to say, there's not much north of the border. There is a guy in Aberdeen who I know has signed up. But there you are. So, and we are about within the next week to hit 1 million people. And that's been done in less than a year. So you can see this is not something that's not of interest to people. People really do want to know what their health profile looks like. Are there things they can do? And it will provide, I think, a really interesting opportunity to explore how you manage these populations in real life. It's also crucially important that we recognize that we're trying very hard to get a diverse population. And at the moment, the population in our Future Health does properly represent the diversity that's in the UK population, which is really good. So let's pretend we got health screening to work. It looks like in this setting, it is going to work, and it is working. What do you do next? Well, really have to have a system to manage people who've got particular health risks. And it was pretty clear to us that the only way to do that is probably to do that in the community. And you need a whole variety of different things. You need digital integration, you need very few doctors, you need a COVID-like strategy, you need to intervene early, do prevention. And you can put all that together in a thing we call One Shot, which was an idea that came out of the Tony Blair Institute, which was the idea that you could actually bundle these things together a bit like we did in COVID, but use long-acting injectables and long-acting interventions to actually create a prevention system which is based entirely in the community. And that's shown in this slide. It's sort of where our Future Health meets One Shot, and that is there's a whole set of things you can do in a community-based model. You can do all the adult vaccines, which would have a massive impact on respiratory illnesses, particularly in the winter. But you could also do health screening, as we do in our Future Health. We can do cancer screening with ctDNAs. You can do a whole variety of long-acting other interventions that can control many of the chronic diseases. So if you imagine this, the advantage is the capital infrastructure is very light, needs to be linked in through a digital system into your records in the NHS, but you can get all this stuff done simply by responding to a text message on your phone, and that should get you in pretty good shape. So I think the possibility here is enormous, and that is it's a sort of COVID lesson, and that is you don't need hospitals, you don't even need complicated clinics. You can do this in a tent in a parking lot if you want to do it properly, and you can provide people with routine, regular preventative interventions for diseases that they are particularly at risk at, and you can focus your public health and prevention strategies where they'll have the most effect. And I think if we spend the next 5 years getting that going, then I think some of those curves you've seen are going to start to turn around, and we will have a sustainable healthcare system into the future. So thanks very much.
So that was really fabulous. I think we could probably spend all day speaking to you and following up, and we probably want to do that actually and get some of your north of the border things moving too. But I know that you're going to join us for the next session, and there'll be time to have more of a panel discussion with you on some of those questions. So I'm just going to hand over to Denise now to take us through the next session. Thank you.
Thank you, Christine. Good afternoon, everyone. You will have spotted that I'm not Jane Grant. I'm Denise Brown, standing in for Jane. I'm Director of Digital Services here in NHS Greater Glasgow and Clyde, and I'm delighted to introduce this next session. We have 4 presentations from 6 speakers representing the full end-to-end pathway for research, development and innovation across health and social care in Scotland. We have Professor David Lowe, who's going to talk to us about the regional innovation hubs and their role, then followed by Carrie Thomson, Programme Lead for Innovation and Collaboration in the Chief Scientist's Office, who will present on the Reducing Drug Deaths Innovation Challenge. And then Dr. John Thomson, Associate Clinical Director for CFSD, and Jason White, Head of Innovation at CFSD, will present on the ANIA pathway and that process. And then the final presentation will be from Tom Steele, Chair of the Scottish Ambulance Service, and Professor Dame Anna Dominiczak, Chief Scientist for Health at Scottish Government, who will present on the Innovation Design Authority and the governance and process relating to that. So I'll hand over just now to Professor David Lowe, who's the Clinical Director for Health Innovation at the Chief Scientist's Office. He's also the West of Scotland Testbed Lead, and he's an ED consultant here at the QE in NHS GD&C. I've worked with David for a number of years. We've worked on a range of innovation projects, and he's a real advocate for how innovation can transform services for the benefit of staff and patients. So thank you, David.
Thank you very much, Denise. And I suppose the first comment is thank you very much for the organising committee to invite me to come and really outline the regional innovation hubs and their benefit around about strategic investment and capability to support end-to-end innovation. I think I've got to say that I work for Anna Dominiczak within the CSO, and really what we're trying to do is build together that triple helix approach of collaboration across from industry and academia, working within the NHS to really be able to realise some of those benefits. Challenging gig to come after Sir John Bell, the architect of OLS, and some of the work that we are doing within Scotland that's going to be outlined throughout this session is really defining that. So demand. So I think we've heard a lot about rising age and comorbidity. My clinical home, as Denise has said, is the emergency department across the road. The number of ambulances outside are often a really clear, media-friendly manifestation of the demand we're feeling. Equally, all of us clinicians in the room, decision makers in the room, feel that demand in different sorts of ways, and it's really our approach to how do we respond to that. As Denise has very kindly supported, as well as Julie Brittenden, the ANIA Director for Glasgow, one of the pieces of work I'm involved in is around about COPD digital services. And it's now at the point that if a patient comes into my emergency department that's not on that platform, and Chris, Carla and I are hopefully going to sort that over the next year, then we're going to start to see people coming in, and hopefully actually not coming in at all at that point, but if they are, we're going to have deeply understood what's going on with that patient, how we can optimise their care pathway, either by new therapies or potentially other interventions as well. Demonstrating value for ideas is a collaborative effort, and I would encourage colleagues to look at the websites of the regional innovation hubs to really see some of the opportunities that are there, both to collaborate in some of the projects that are currently happening. That's deeply dependent on working with industry, but equally also the talent within the NHS as well. And increasingly, it's how do we pull in the universities to really think about how we gather evidence, which is really the crux of what we seek to do within the regional innovation hubs. The activity really goes across the breadth of activity that we'd expect to see in a healthcare system, and that's everything from bilirubin testing in neonates all the way through to complex long-term conditions, leveraging AI. And while a single individual might have a hypothesis, an idea, it's really how do we bring together a team to be able to deliver that and evidence it, and that's often the challenge, and that's why the CSO is invested in the regional innovation hubs, is really to bring that team together, which is often a clinical lead, project management support, and then as I'm going to go on to describe some of the assets that are available, recognising often the opportunities, thinking about health and medtech, but increasingly also consumer technology and how that interfaces with how we deliver care. So for those not familiar with open innovation, it's a concept of an organisation sources ideas internally, but also externally. And within NHS Scotland, innovation hubs are really the nexus for us to be able to deliver that. The Hub's activities are, of course, prioritised with demand signalling, Scottish Government priorities, but equally the market as well. What does the market want to develop? We've already heard from that from Victor earlier. The market will tolerate innovation that's adoptable and somebody will pay for. But really what the focus of within the regional innovation hubs is how do we develop ideas, concepts that speak to market opportunities, but equally for the NHS. And that golden thread is really important. How do we take that golden thread of ideas, that end-to-end innovation, and turn it into a pipeline? And that's what we're going to hear throughout this session. Of those innovations within the ANIA process, about 50% of them came through regional innovation hubs. And it's really an opportunity for us to develop products and services that respond to our needs within NHS Scotland, but equally the impulse and what we need companies to think about is that Scotland is not just going to be your single customer, that how you're going to produce products and services that can go worldwide. So the regional innovation hubs are regionally based, unsurprisingly, in north, east and west. And really it's to be able to engage through that triple helix working from early feasibility study through to adoption. And increasingly we're seeing really rather complex projects coming through, as Anna's already highlighted, around about AI for chest x-ray. And we saw from John earlier around about that piece around about 50% of patients presenting with cancer into the emergency department. How do we leverage the data that we collect, that we've already discussed today, to really provide a provocation to produce new solutions to respond to those challenges? And yes, digital architecture is critical to that, but really we need to be able to develop a portfolio of activity that responds to those priorities in terms of social inequalities, as well as the healthcare delivery challenges that we're experiencing. Each of the hubs has a particular flavour around about what they do, which is again based upon talent and the board's priorities, recognising that Forth Valley, for instance, leads some of the work around about digital dermatology and dermatology with AI and ophthalmology. The North of Scotland hosts the Future Flight and Drones programme, and the West of Scotland is predominantly focused on long-term conditions, cancer, again predicated by some of the interests and equally the needs of the board as well that have been expressed. In terms of the facilities and the access that we provide, it's really, again, that end-to-end innovation, recognising that some innovations will come very early and will need support in terms of engaging and scoping. Sometimes that's access to data, sometimes that's access to just clinicians and patients to be able to talk through the idea and be able to consolidate it. Moving through to thinking about clinical validation, how do we activate the universities around that clinical academic expertise, but also key components such as clinical trials units, safe havens, health economics. It really builds evidence to support decision making. And as colleagues are going to describe through the rest of the session, evidence to support decision making is absolutely critical. How do we develop that early? How do we develop the minimum amount of data, recognising that trials are costly, that supports decision making based upon the needs of the population, but also the risk that is inherent within the system as we experience it right now. And networking of assets, I think we've described there's not very much money in the system at the moment, so therefore how do we not duplicate the assets that we have, reinforce their use? And really the challenge for colleagues in this room is the regional innovation hubs exist, how do we work collaboratively together using those assets? And often the regional innovation hubs core component is project management, to be able to steer individuals, companies and academics towards their needs. Do you need to talk to a clinical trials unit and methodology? Do you need to start to think about the health economic discussion, or do you need to build the clinical trial for regulatory approval? Or post-CE marking products, which is increasingly the space we're in, is how do we provide the evidence, again, for decision makers to proceed with comfort to deploy these nationally? And I've unashamedly stolen a slide from Dame Anna around about porosity, because it's really that idea of how do we create those shared assets, shared ideas and the shared language to be able to do this. And increasingly as we brought in things like the Tech Scaler programme, is understanding the entrepreneurial needs of both NHS Scotland workers but the wider population as well that actually do have great ideas, and how do we hand off to the appropriate individuals to be able to support that. I think it really becomes the concept of how do we squeeze value out of that triple helix as well, recognising that we have resources, we actually have great talent, but it's being able to pull that all together and create an infrastructure to do that. So again, that encouragement to think, if you have ideas, you're wanting to be able to deliver that clinical trial, how do we do that? How do we do that in a streamlined fashion that allows us to use the assets we currently have rather than duplication? And then finally, I'm very aware that John Bell's in the room and describing the OLS challenges. throughout the process of the regional innovation hubs, we've really sought to, through pre-procurement purchase and programmes, to be able to challenge the environment, to be able to say, these are the particular opportunities we have, and that might be in mental health, as already been outlined, eye health, as well as thinking these larger challenge areas. Increasingly, as we're moving towards new funding challenges, we're looking at colleagues from CivTech, Office of Life Science, and as well as noting that often Office of Life Science is now pushing money out through Eye4Eye programmes as well. And it's again, how do we as clinical researchers and academics utilise that funding and be able to convincingly bid into it, often recognising that we're going to work collaboratively with NHS England colleagues. So what I'm going to do is pass on to Carrie, who's going to speak with one particular area of challenge that really provides a confluence of both our priorities around public and social health, and how do we change those determinants, but again, stimulate the regional innovation hubs and that triple helix to be able to respond to that challenge. So thank you very much.
Thanks very much. I thought I'd have more friends up here, actually. It feels a little bit lonely. Right, what are you on? So this one's me. Following on from David, I'll be focusing on one of the CSO-funded innovation topics. So whilst a number of the innovation areas are in partnership with other funders that David had on that slide there, this example on reducing drug deaths is linked in with one of the UK government healthcare missions, which, as I'll cover, significantly increase both the size and the potential of the programme of work. But to start, let me start with a little bit more information on why reducing drug death was identified as an area for the CSO to support via the Innovation Fund. So as we know, drug use and the associated harm risk of harm and death is exceptionally high in Scotland. In August, the stats were published for the 2022 drug misuse deaths, a summary of which is here on this slide. Despite a decrease, and that's a significant decrease of 21% in drug-related deaths last year, Scotland still has the highest rate in Europe, and at 19.8 per 100,000, that's double the rate for the UK as a whole. Also, looking forward to the 2023 figures, early indication shows that this reduction is not likely to be repeated or even maintained. So in answer to this, Scotland launched a national mission in 2021. The main focus was on treatment and recovery, but it also supports the use of emergency life-saving interventions such as naloxone and using digital technologies to prevent drug-related deaths. These are the key elements that we were able then to take forward in the innovation work. So building on that national mission, CSO were able to respond by including this within our demand signalling plan. The open innovation process uses this triple helix model, brings together experts from health, research and industry to identify and prioritise national gaps, which could benefit from innovative solutions. To do this, we set up the CSO Reducing Drug Death Innovation Consortium Leadership Group, a little bit of a mouthful there, chaired by Professor Alex Baldacchino. And it was this group that took the lead to develop the Open Innovation Challenge. So building on that ODART report that was produced by the University of Stirling and St Andrews University as a landscape review, that was the base of the work where we started. And actually the work of the Innovation Consortium was really fortuitously timed with the launch of the UK Gov Addiction Healthcare Mission. So policy colleagues came to meet with the consortium, talk about the synergies with the priorities and the potential to work together. And working with co-funding from the Office for Life Science, we were able to increase that innovation fund from 500,000 to now near 6 million. So I'll speed through this, conscious of my time limits, but it was to say that as part of the life sciences missions, the life sciences vision published by the UK government in 2021, there were 7 healthcare missions identified that would use that triple helix to make rapid progress. And it was the introduction of this 8th mission, following the launch of the 10-year drug plan, that we were really able to link into. So for addiction, the UK government deployed over £30 million, or a commitment of £30 million. This was looking at both innovation opportunities and the addiction research ecosystem. And the CSO is working in partnership with both of these themes. Anna hosted a visit from the mission chair at the end of summer, and it's under this second one, the innovation competitions, the funding of which we were able to work in collaboration with them. So this brings us on to the detail of the Reducing Drug Death Innovation Challenge. Excuse me. Should have bought a wine glass. Working together, the CSO Innovation Consortium and Office for Life Science developed this challenge statement to fund digital technologies and therapeutic solutions focused on detection, response, and intervention in potentially fatal drug overdose episodes. So the challenge itself has been led by the Chief Scientist Office, acting as a delivery partner for OLS, with approval from the Minister of Drug Policy, as was, and the programme is supported by NHS Fife Innovation Team as part of the HISIS Innovation Hub. So the challenge used the SBRI model. That's a small business research initiative that was run through Innovate UK. And as I say, it was invested with £6 million looking across the 3 themes of detection, response, and intervention. So the key kind of priority areas we were looking at, specifically the consortium is really keen to promote user-centered. So the project design should be user-focused, include a co-design and co-production elements. Other priorities included that technologies should enhance the ability for people to self-monitor, to enhance that surveillance element through simple, live and intelligent data. And the final point here was around that intervention therapeutics. So the 2 competitions ran simultaneously. The first we looked at was a 2-phase SBRI, kicking off with feasibility studies. Each was funded for up to £100,000. The second was a single-phase competition, direct to phase 2. And that was for projects at a more advanced stage of development, and that was for funding up to £500,000 per project. The competitions closed in April this year, and the applications underwent evaluation by the independent group of experts. And that brings us up to date. So we've got 12 successful projects were awarded contracts, 11 feasibility projects kicked off in September, and we're drafting the contract for the phase 2 demonstration project as we speak. So this one shows the location of the projects. The ambition was to get a good representation across Scotland, but it was also ran as a UK-wide competition. Here you can see the geographical spread, and across the themes, 7 of the projects looked at detection, 6 were linked to some kind of alert or responder pathway. In the main, they were wearable devices, monitoring a range of biomarkers, for example, respiratory rate, heart rate, movement, motion, voice, other digital behavioural markers. There were also 3 projects looking specifically at intervention. The first was the use of drones or drone technology for the rapid deployment of naloxone nasal spray. The second, a more portable format of dispersible naloxone, with the ambition to encourage people who use drugs to carry the dose around with them, say in their wallet. And the third, a transdermal patch with combination antidotes for opioid and benzodiazepine overdose, which is an increased risk here in Scotland. So each project was required to work in partnership with a testbed to help the company develop and deliver their proposed solution. So most of the other CSO SBRIs that we've run have been focused on Scotland, and the companies have worked with the 3 regional innovation hubs that David just spoke to. In this competition, we extended this innovation infrastructure across the 4 nations, using the NIHR and the AHSNs, or the health innovation networks as they are now, and the equivalents in Wales and Northern Ireland were all involved in the development of the competition. So when you look at the location of the company and the testbed partners now shown here in blue, it increases the presence of the projects across all 4 nations, which we were really pleased with. And here's a quick view of the successful projects. These are the ones that have an affiliation with Scotland, either that the company is based in Scotland or that they're working with a Scottish-based testbed. That's 8 of the 12 successful projects, a mixture of university, NHS-led projects, private companies and spin-outs. From top left here, the West of Scotland Innovation Hub is supporting 2 projects, working with the University of Glasgow and NOM Health. I don't know how you say that. That's on a wearable device and alert. HISIS in the South East Scotland Innovation Hub are working with 3 companies, Moody, based in Edinburgh, MESOX in Leicester, and Zio Health in London, who are looking at that self-monitoring of benzodiazepine use. The Scottish Ambulance Service, I said I'd get a mention, is working with the Welsh Ambulance Service, supporting SignApp, an app, and the company based in Anglesey, they're developing an app to build a network for the naloxone community responders, and also to provide training in administrating naloxone. Salvation Army Hostel in Stirling is working with DARN, that's the Drug and Alcohol Research Network based in Northern Ireland, acting as test beds supporting the Manchester Metropolitan University project. And lastly, the Scottish-based company Numawave is working with the South London Health Innovation Network, but also with the University of Dundee. So this provides an example of how we in Scotland have been able to harness additional funding through the OLS healthcare mission to fund translational research in this specific area. Next steps, I'm nearly done. See Anna looking at her watch. Next steps, we're looking to extend this partnership work on the addiction mission with follow-up funding into a new innovation challenge in this area. But also we have links across to both the cancer and the dementia missions. But we wanted to share this example, not just to champion the work of CSO innovation team and the innovation hubs, but also to highlight the opportunity through these healthcare missions for this community to apply and receive funding in these areas. This will continue to strengthen the ties with the UK government and to work together to make Scotland and the UK a leading location for life sciences investment and for innovation. Thank you.
We are now going to spend a few minutes talking through ANIA and introducing you to ANIA, which is the Accelerated National Innovation Adoption in Scotland. So this is Jason. He's the Head of Innovation at CFSD. So for those of you who don't know what CFSD is, our job in the organisation we work for is really looking at to pioneer new ways of working in the healthcare system so that we can scale that across Scotland. And innovation is a major part of our work.
And this is John, he's a gastroenterologist in Aberdeen, and also an Associate Clinical Director in CFSD. And if you get confused, he's the one on the left. So, where are we going to start? So we're going to start in the future, because the future is a very exciting place. You don't need to be a subscriber to The Lancet to know what's coming. You just need to pick up the paper or look online. Almost every day there's a new trial, something that's going to come and revolutionise healthcare system. That could be pharmacogenomics, it could be augmented reality for surgeons, it could be artificial intelligence. We know the future is out there and it looks very rosy and we can see how things are going to get better. But the challenge for us is that we need the future now. These technologies are essential because the status quo of our system, as we've heard, is not sustainable. We need to shorten that time period from these exciting new things in the future to what we need now to fix our key challenges.
So we've heard and we all know how broken it is when we're out there working. These reports show us that level of brokenness, that really what is coming, as so eloquently was put in the first speaker of this afternoon, we really are not equipped for and we're not ready for. But as Jason was talking about there, we have an innovation landscape that really feels like it should be Formula One. We should be driving this forward. We should be getting those new things out there because they're so exciting. But the reality that we see is our innovations are stuck in that mud. They're just stuck there, and we don't quite manage to get them out to scale. And there's a number of reasons for that. We'll touch on some of them, and you guys know that. You know that detail out there already. So sometimes we have an innovation, and does it work? Will it work in my environment? That's a common question that's asked. Will it work where I am? The complexities, Denise to my left-hand side here, the complexities of our local e-health and our digital infrastructures, how do we get that piece of tech, that piece of innovation, how do we get it to work with what we've got? How do we change what we've got? How do we take that, move right to the left so that we're doing this properly? But really, we've got to manage what we've got and get that seamless transition as best we can.
So here are some of the challenges, and one of them, the bottom right, is one I'm sure it's familiar with many of you, which is funding. Money is so vital to enable national adoption to happen. It's a key challenge that we have to overcome. You know, NHS Scotland is a federated system. There are 14 different health boards. There are many budgets and budget holders. And one thing that unites everyone is that those budgets are under increasing strain. And new technologies might be seen as, that's a shiny new thing, it's a nice to have. How do we make the case for national adoption in that context? And we may even get the money for a particular purchase of a particular piece of kit, but it's the full cost of change which is so important for these things to become important. There's other challenges, of course, as well. Procurement, whereby we have to move from that pre-procurement phase to national commercial tenders and so on can be challenging. And as we've heard before, information governance is a key challenge. And of course, there's lots of good work between the 14 boards and then they're sharing practice. But we do know from some of our experience that there are extremes. So a technology we're looking at, one board was saying, oh yeah, we use that all the time. That works great, no problems at all. And another board's view was, can't really do that. That's breaking the law. So, you know, there's just a lot of disparity out there. So we've touched on a few of the kind of technical challenges to adoption, evidence, IT infrastructure, fund and procurement. But for me, the most challenging one is the top left there, top right, hearts and minds. It's the human aspect. You know, when new technologies reach the real world seems quite messy and is full of thousands of doctors, nurses, other healthcare professionals busy delivering care to their patients. And we have to try and get them to do things differently because technologies don't operate in a vacuum. They need changes to clinical pathways. So we need to bring them with us. That's a key aspect. And how we do that in ANIA is through a couple of things. Firstly, we engage early with the clinical community through the specialty delivery groups, which brings clinicians across Scotland together. So we co-design how we do that. But it's also important how we frame technology or new innovative technology. It's about the value it delivers to patients. It's not about the particularities of the technology. It's the difference it's going to make to the care they provide to their patients that we focus on. So what is ANIA? It's really two things. First and foremost is an assessment process whereby we can all agree where the high impact innovations are that are going to make the big impact to Scotland. And secondly, it's a team across organisations, both national boards and territorial boards, who work together to bring those to the front line at pace to deliver that value.
And it's how do we take that piece of how are we going to do this? So we have a number of bodies who are working and a number of groups who are working within Scotland in innovation, some of whom are in the room or some of whom aren't. So what ANIA looks to do and has done is take those together to the partners that you see on the bubble there on the left-hand side of the screen. And those partners work under the governance of the Innovation Design Authority that you're going to hear about shortly, and look to how do we scale that into all of the boards that need it. This isn't necessarily about a niche thing that needs to happen for a niche area. This is about what are those high impact changes that we can deliver across the whole country. So that happens through this process. The important bit to think about here is those three bits of the process. So there's that value assessment we talk about. Then we look to the clinical pathway and what impact that's going to have, and then that detailed delivery plan. So it's really about how is this going to be delivered across all of the boards, across all of Scotland. Very importantly, those colours there represent the partner organisations. So this isn't CFSD, this isn't a group doing this by itself. This is that partnership of everything working together to deliver the projects across Scotland. So there is a lot of detail there. You're going to hear a bit more about it later on, and we're happy to discuss that as it goes forward with folk as they're interested. So at that implementation phase, we have two projects that we're really looking to scale and drive across the country just now. So the first one of them is the image triage at the point of referral. That is, the procurement is just in the process of concluding for that. We're just out of the standstill period, but not quite awarded the contracts. I can't tell you who it is yet, although that will be exciting when it comes the next week or so. And then also looking at a national onboarding team for that closed-loop diabetes system. It's a great example of there was a bit of kit. This national onboarding team will help to roll that out and get it in place across all the boards.
And we've also got 7 innovations which are going through that assessment stage of the ANIA pathway. And these are what's hopefully going to become the implementation programmes in the next few weeks and months ahead. There's 7 of them there, but I'm just going to pick out 3. And I think it picks up David's point about that close working between innovation hubs and that broader ecosystem and ANIA and how we all flow together. First one is around that chest X-ray AI project, which is up and running in Grampian and Glasgow in terms of testing a new technology that could shorten the time between chest X-ray and diagnosis and treatment of lung cancer, improving survival rates, which is really exciting. Another project has been developed in NHS Tayside, whereby they're using a gene test for all their patients who've had a stroke or TIA. And if we deploy that across Scotland, it could prevent over 200 strokes per year. And again, it's that framing piece in terms of value. So we're looking about whether we should extend that from 1 board to all 14 boards. And then the third piece, I think, is really fits in with a key theme we've heard today about population health and prevention. Precision public health is a good example whereby we're looking at digital technology to deliver a national diabetes prevention programme, focusing on those with pre-diabetes or non-diabetic hypoglycemia. And we think that could prevent thousands of people from going on to develop type 2 by addressing obesity and supporting that behaviour change. So we've got a really exciting and interesting pathway that we're working through.
So hopefully that's introduced you to ANIA. ANIA, the pathway, not Anna, the chief scientist. I have been confused in meetings before. Apologies for that in advance. And I really want to just say that ANIA is the main road, and it's the new main road for those high-impact innovations that are happening, but it's not the only way that we can work. And also, importantly, we don't want to build a motorway and then just clog it up with lots and lots of things. It's only funded at the moment for 1 or 2 high-impact changes of programmes, so we can't do everything. Very, very importantly, what we would highlight is that this is about funding the change. It's not about funding the technology. If you drop a bit of technology in, I think everyone in the room has probably seen that not work in their clinical environments. So what we need to do is, what is the transformational change programme around this to allow things to change and drive forward? And as Jason has highlighted, and as David said earlier, and Carrie gave the example of, this is about how do we plan that transition to move into normal business right from the start of doing this. So it's not like, oh, we've got a shiny new thing. Oh, what do we do with it now? We need to think about how we drive that forward. So we would argue, just to leave you with this slide, that we need to get ourselves out of the mud, and ANIA is the way to get us out of the mud. There are still other routes to innovation scaling across Scotland, but ANIA is the place for those high-impact changes, and we should see that come to fruition in the next few months into years.
Right. So this will be a different duet. Tom will speak, and then I'll show some slides. We're not going to do that act that you did.
I'm the warm-up act, ladies and gentlemen, for Dame Anna. Tom Steele, I'm chair of the Scottish Ambulance Service, and I just see Jason sitting there. You know, Jason, I bet you didn't think you'd see me here 10 years ago. I had a career in the IT industry, retired early, got a bit bored and joined the NHS. And Jason was the first person I met, I think, who was then lecturing about patient safety. And they kind of got under my skin, the NHS, and 5.5 years ago, I moved to take over the board chair of the Scottish Ambulance Service. And, you know, just talking about that, you mentioned the Scottish Ambulance Service, you mentioned the drug deaths. I went out just 2 weeks ago in this city with an ambulance crew, and we had 6 incidents that day. 3 were drug overdoses. So this is real. And anything we can do to impact the effects of drug harm is hugely worthwhile. I just picked that one out because it's fresh in my mind. Street Valium is everywhere in this city, sadly. And AI, which we're looking at, will help us identify the patients who are in overdose and those who are having some other respiratory condition. And so it's fundamentally important, some of this stuff. And I want to put it in context, what we're doing and what innovation is all about. And I think back 24 years ago, I was in hospital with acute myeloid leukemia. And so I'm one of the patients whose science has absolutely helped. Many people at that time didn't make it with exactly the same condition as I had, and precision medicine is going to change that and make it so much better. But when I joined the NHS, I just felt that there was something missing. There's so much science development, there's so much technology out there, and yet it didn't seem to be getting to the front end. And I had a conversation with Jean Freeman 3.5 years ago, who was then Cabinet Secretary, and she asked me if I had a look at innovation. And that was about it, really. She just said, you come from a kind of technical background, and maybe you could try and understand why Andrew's and David's work in the Chief Scientist's office wasn't getting through to the sharp end as much as we would like. So they were hearing lots of good things, but also they were hearing lots of bad things from the Chief Executives. And what I was trying to do over the last 3.5 years is build something that would be the bridge between research through to meaningful scaled innovation. And that's really what we've heard about today, really, how difficult it is to build that bridge. We think it should be perhaps easier in Scotland because there's 14 boards and there's only 5.5 million people. But in truth, it's still pretty difficult because within every board there are different structures, there's different, absolutely different cultures, different ways of doing things. The population's different between urban and rural. But that is absolutely what we are trying to do. And, you know, my role, I guess, is, I mean, I'm not a clinician, I'm not a scientist. You might say, well, what the hell are you doing at this conference? But you know, it is interesting how many people I've spoken to, and, you know, Joyce there came up and thrust a piece of paper into my hand over lunch and said, look, can you help me accelerate what you're doing? So, you know, that might or might not happen, Joyce, but the point is that we're building up some energy in the room. And I've worked closely with a lot of the people we've spoken today. I think that when Gregor was talking this morning and he spoke about, he just went past a quick comment, which was boundary spanners. That's a term I only came across very recently, but it is apparently a real term. And it's not a spanner in the works, although that's how it might seem to some of you. But a boundary spanner is someone who can understand what's going on in all the different silos enough to join them up. And it's hugely important. It just doesn't happen enough where everyone's working very hard and in their own area, but they underestimate the complexity of all their partners. And they think the problem is with them, not with us. We're doing our very best, and these guys over there are just not quite trying hard enough. Now, the truth is there's massive complexity in what we all do. And if people like me and Anna and many of you have spoken today can join that up to better effect, we will be successful in delivering innovation to the benefits of patients. And ultimately, that's what we're doing. So that's just kind of some observations from me for today of what we're trying to do, what the endeavour is, the overall endeavour. And we heard from speakers this morning, particularly, just how important this is, but also how difficult it is. So we're trying. I hear far too often the words, something must be done about that. Almost every meeting I go to, someone will say, something must be done about that. Well, at least we're trying, Anna, and everyone who's contributing to this endeavour. And I think that's probably enough from me, Anna, but I'll let you now talk through a few slides. Thank you all.
Right, thank you, Tom. So we're going to talk about Innovation Design Authority that we co-chair, Tom and I, and it's a great pleasure working with Tom. Tom always puts it into nice words before I show my slides, and you've seen an example of this. So, first of all, why do we exist and the overall objective? So first of all, I think David Thomson needs to put his hand up. David, hand up, yeah. David put us in program for government, and many of you know that the key issue is to be in program for government. We're not quite in the right place of the program for government, the one where money is, but we are in program for government. And that's really important. This is not a joke, this is serious. And David worked relentlessly, and there were several versions, and he kept putting it back up, and we're there. But seriously, we would like, as you heard throughout today, to utilize science and technology to provide things for patients and communities. And it will be both acute and prevention. You heard a lot about prevention, and Jason and John showed you that our projects increasingly go towards true early diagnosis, prevention, doing things better, and it's hugely important. So PFG, September 23, we are there, and this is all about ANIA and IDA. Now, it is, of course, hugely important, and I don't need to repeat to this audience. That's been already rehearsed. But if it is true that in Scotland we will have 21% more of need for our services in 2043, we certainly would not be able to deliver it. So, as Einstein said, doing more of the same is not going to answer the problem. And I think you all agree with this. Now, how have we responded to this challenge thus far? We young, we new, we're still learning. It's a new initiatives, both ANIA and IDA. But we felt that we need that end-to-end innovation pathway, and I think that has come through previous presentations, and this is real. I think in some jurisdictions that we've been watching, maybe other nations of the UK, there is innovation here and research there. It seems to be separated. I don't think that's healthy. I don't think it's going to work for health. I think it might not work for any area, but certainly not for health because of the complexity, risks, ethics, all these things. So what we would like to do is, with Tom and the team, Innovation Design Authority has several senior colleagues across health in government, NHS, chief executives from our health boards, and also industry representative whom you'll meet in the next session. And this is Mark Logan sitting here on the left. What we want to do is increase risk appetite. Tom frequently talks about our risk appetite. I know some colleagues in our system, probably not here, but who knows, with risk appetite at -20. We need to be at 70, otherwise we'll never win. But also, clearly we don't have money to do everything we would like to do, as you heard. So we need to prioritize those most transformative, most value for money, most value of patients propositions that come our way. And that's what IDA is for. We meet every month. We have a gateway system that you'll see in a minute. But before we can do it, we need that research and development, that innovation hubs that David so nicely described, the triple helix collaboration, and we need industry. And as I said in the morning, and I'll repeat again because I believe in it strongly, I haven't seen great health innovations without industry impact and involvement. It just doesn't happen. We can't do it neither in ivory tower nor in the ward or laboratory or the clinic or even in general practitioner's office. We need industry because industry knows how to work in innovation, how to provide profit, how to take us through the complexity and difficulty. I mentioned Industry Partnership Group before. There are many colleagues who are part of it in the audience today and others who have been helping us. We want to talk to industry. We want to talk to industry a lot before we can collaborate. You can't collaborate if you don't talk and interact, and we all know this. I mentioned the tech scalers and our twinning in the morning, but now that Mark is here, I will mention it again because good things need to be repeated many times until people believe us. So this is twinning between tech scalers that Mark and colleagues in Codebase run with our 3 CSO regional innovation hubs, and it's a two-way collaboration. It allows the tech colleagues to come into clinical environment and help us to do new things, but it also allows our innovation fellows and our other clinicians, wherever they reside, they could be academics, they could be NHS, they could be anything, to go and learn how to be entrepreneurs. And it's working, and we've had a meeting in Edinburgh with 200 people and a great enthusiasm around the room. Now, AI is mentioned everywhere. AI is in the news, AI is in television, but we're doing it in Scotland already. We just don't tell anybody, we're quiet about it. So I thought I would tell you. You already heard from colleagues. That's a fantastic initiative called GRACE, great name too, in the Northern Hub in Grampian, that is succeeding and soon will be ready to be evaluated for ANIA, succeeding to diagnose and act on lung cancer much earlier than in a normal clinical process. And that's great. And as I mentioned to colleagues, I have seen many happy radiologists, probably the largest number of happy radiologists in one place I've ever seen in my life when I visited Aberdeen. Now, it's not only chest x-rays and radiology, but also dermatology, of course. And I'm very grateful from colleagues for this slide. This is another group working in 2 of our CSO regional innovation hubs. This is called 25 for 25, diagnosing skin cancer within 25 minutes by 2025. I always ask to Collins, could we do it earlier? But that's just me. They say they need their time to do it properly, and I do agree. But you'll see that we are preparing for this group to be ready to do more and spread it around Scotland. So Innovation Design Authority has been established in August 2002. It really is that force to look, evaluate, have a very strict gateway rules, what can go further and what might not be quite ready. But we know that we will fail, and if we don't fail, we're not doing it right. Yeah? Innovation means that we need to let some things go forward that are not quite ready, and we need to be prepared for this in Scottish Government. We heard about ANIA. ANIA is the most important part of it. And as Jason and John beautifully described, this is the collaboration that goes across our NHS, these national health boards, and we can't do anything without that whole innovation team. I like this pathway, which is slightly different than their pathway, but everybody has their own favorite slide, as you know. And this one shows both the pipeline feed, what comes into ANIA pathway, but also that interaction with chief executives and other clinicians, colleagues in charge in all territorial health boards, because colleagues need to want this innovation. We can't impose anything. It doesn't work. It has to be wanted and needed. And I think the best moment for me as co-chair of IDA has been when Jane Grant and I went together to present to all chief executives of all health boards across Scotland at their so-called private meeting. And discussion was, yes, we want to do it. Could we do it now? I want to do it quicker, faster. This is obvious. And it was about diabetes, and it was about prevention. And I think we need to use this excitement, to use what's happening. And one of the chief executives, I don't think she's here, Jan Gardner, said, Anna, this is oxygen in this difficult time. So let's deliver oxygen. That's what we do as clinicians. I thought I would show you the two that are already out there and happening. The digital dermatology fully funded program, it's out there being developed. We monitor closely timelines and how it's progressing. And you can see, every clinician in the room can see the benefit. You've already made a diagnosis. Yes, this is malignant melanoma. You don't want to wait several weeks for your appointment. You want this to be accelerated. And that's the way to do it, using the digital system. And you can imagine that we already layering that 25 for 25, this AI in dermatology on top of it, as colleagues are evaluating and preparing. We're already thinking how we'll add that layer of AI activity on this. And then, of course, we have closed-loop systems that has been shown that way to help people, communities with type 1 diabetes, but also to help our NHS. You can imagine that number of admissions with diabetic ketoacidosis and terrible hypoglycemia, perhaps death, but also long-term complications will be enormously reduced. The problem with all this is that sometimes benefits, fiscal benefits, will be 10 or 20 years hence, but that doesn't mean that we shouldn't be doing it. We just need to explain this to our finance directors. Now, you've already seen next 12 months, so I don't need to go on about it. There are lots of hugely exciting projects there. We might not be able to do them all. If we have 2 or 3 or 4 great successes in next few months, that would be absolutely wonderful. And Innovation Design Authority will be a feature to stay in our Scottish system. So thank you very much, and I think we have some time for discussion with all of us. Christine.
Thank our speakers. I think I'd really like to, in particular, thank Anna and Tom for all their work on in leadership in the Innovation Design Authority, and you've heard from our speakers some real-life examples. We just take 1 or 2 questions before we hand over to Jason for the next session. So could you just let me know by putting your hands up, please, if anyone has any questions for the panel?
Tom,
David?
Told us very clearly that more doctors aren't going to be helpful, which is interesting. But then as a throwaway line, he sort of implied that we were educating them incorrectly as well. And I don't know who the we was there. But John, if that's the case, the important authority is the General Medical Council here. Because, there's you're handed down something. My very specific question is, if this is the case, is there a dialogue with the regulator?
Yeah, so it's a very good question, and you're absolutely right. My personal view is the system is massively over-regulated, and it's one of the reasons people hate it. And it's one of the reasons young doctors are all headed for Australia, because they really hate the overregulation. So I think there's a lot of introspection required at the GMC, because we haven't got to the point where we've got a sustainable model yet, and they ultimately have to be responsible for making sure that happens, particularly with their oversight of medical schools and what people get taught. I think most medical schools make an effort to try and teach people the principles of prevention and public health. I think that gets into the curriculum. But in the absence of a body of people who are doing it as the exemplars, as the models, as the mentors, it's really hard to build capabilities. And I think that's sort of what we need to try and press on with. So, but it's a very fair question. And I mean, there's a whole nother issue about over-regulation in a variety of settings, including healthcare.
Thank you, John. We'll just take one more question, but I think there's probably time at the end of the session, isn't it, for some networking? Is that right? So if anybody wants to speak to any of the presentations that you've heard and wants to follow up, there'll be time to do it. So do we have
Aziz.
Yeah, so John, this came up earlier about the need to really try and articulate some grand challenges that the kind of whole data innovation piece can get behind. The COVID was a kind of a natural example. Nobody had to think about that. But I'm thinking about sort of the obesity issue. And I wonder if there's something sort of more proximal to that we can target, because obesity is quite a difficult one to land politically, I think. But there's been phenomenal progress around diabetes prevention, diabetes remission. A lot of that's come out of Glasgow, actually. I mean, we can now sort of, the vast majority of cases of diabetes we can turn around. So is that one that's worth gunning for, do you think?
Yeah, so just to get back to my Canadian roots, when you're out chopping down trees, it's usually quite good to go for the trunk rather than the branch. And the obesity thing really is I accept it's hard, and I accept it's all new. But, you know, the best way to deal with the diabetes epidemic is to deal with the obesity epidemic. And you're very lucky. You've got Naveed Sattar, I think, is he in Glasgow? He's in Glasgow.
Glasgow.
Yeah, and you know, he is the champion for the obesity mission. And I was joking with him the other day. I said, maybe we just shut down the NHS and just deal with obesity. Because if you did, that great long list of stuff would just basically go away. Anyway, it was a joke, so don't. I don't want that in the newspapers. But anyway, you can see, I mean, it is so central. And I'm a fast learner on this, because if you'd asked me a year ago, it wouldn't have been on my list. But I mean, if you're looking for something really to go for, that might be it. I mean, diabetes is fine. I think, you know, I wouldn't argue about a big diabetes prevention program. Obviously, that's going to work, and people have got that into play. Yeah. But, you know, just think a bit more boldly, because, you know, the new tools that are available for obesity are unbelievably powerful, and I think will have a huge role to play in medicine. So, you know, in a sense, you you always decide to follow what the technology lets you follow, and you know, when opportunities open up, you should run for them, because those opportunities weren't there a year ago, but they are now.
So can I add to this, Aziz? I think you're right that society probably would accept easier that we prevent diabetes, but actually we're doing the same thing. So 2 programs that have been on our slides over the last 15-20 minutes. One is diabetes prevention, digital diabetes prevention, and the other is remission. And you're right, initial studies have been published from Glasgow and Newcastle. There's fantastic evidence there. So we hope to implement that digital program for both. But all we see, John, there is weight loss. And weight loss is the actual indication of what's happening and everything. So what you're doing is you're doing diabetes first, but next time, when we show that it works, why not to apply it broader? Because diabetes prevention, as you know, is simply the borderline state that you don't allow to progress to other disease. You can do the same even earlier with obesity. Why not?
I would maybe just finish by saying that as we're looking ahead to our population health plan, certainly our approach to making inroads in obesity is likely to be a central component. So we want to understand how innovation can really support that, and of course working across the UK and beyond. So all really great, relevant stuff. So I think we'll leave it there for this session. Thank you very much to all of our contributors today.